All right, so in this video, we're going to be demonstrating cardiac emergencies. So Jim here is going to be having chest pain. We're going to work through the assessment, the treatment, and everything like that. Remember now, we've been through pharmacology, so any appropriate drugs and anything like that is fair game in these scenarios. And just remember too, and not just with chest pain, but any other scenario as it relates to pharmacology, just because you can give something doesn't mean that you should give something. So make sure you're making, critical decisions, good decision making capabilities of, what you're going to use to treat and how you're going to do so. So again, just to briefly shorten this up a little bit, we've already gone through our scene safety, scene safe, our BSI is on. We already know our number of patients and things like that, so we're just going to jump in basically right with general impression. And remember that general impression too is what your patient looks like when you walk in the room, so kind of that door frame view when you're walking in, how they look. So initially I see Jim here. I walk in the room, he's clutching his chest. I can see by his facial expressions that he appears to be in some sort of distress. So I'm going to walk in. Hey, my name's John. What's going on today, Jim?
Oh, my chest hurts so bad.
Okay. All right. Have you ever had this before? Or?
No.
Okay. All right. So I know he's got an airway. He's talking to me. I don't hear any weird noises coming out of the airway, so right now I know his airway's patent. But remember, with all your ABCs and along with your scene safety, this is a constant and a fluid process. So just because it's fine 1 minute doesn't mean it's going to stay that way. So I'm going to move on into breathing. I'm going to take a look at his respiratory rate. It looks like, even though he's having chest pain, that his respiratory rate is altered a little bit as well, which is to be expected. One thing to consider too with chest pain in specific is you kind of have to figure out which came first, the chicken or the egg, to a point, if you've got both chest pain and respiratory problems. Are they having chest pain because they're working so hard to breathe, or are they having respiratory problems because their chest hurts so bad? So I see he's breathing. He's breathing a little bit rapid, and it appears to be just a little bit shallow, which is to be expected, especially if he's having chest pain, especially with the presentation of him holding his chest. Usually that'll make patients feel better or feel like it's making them feel better by pushing it onto their chest. So I'm going to listen to lung sounds real quick. Again, you want to listen about 2 or 3 places in each lung with a full breath cycle. You want to listen to your uppers. You want to listen to the middle. And you want to listen to the lowers and the bases. Okay, so his lungs are clear and equal. So I'm not worried about any noisy breathing or anything like that, and I don't audibly hear anything with that as well. So I've assessed his rate and quality. I've assessed his lung sounds. I'm going to go ahead and apply an SpO2 monitor. Can I get your finger, Jim? Go and set this up on his leg so we've got a little bit more space to work with. So it will give me a pulse and it will give me his SpO2 reading, but we don't necessarily want to just rely on this, so I will want to take a manual pulse as well. Are you having respiratory distress with your chest pain as well?
Yeah, I'm a little short of breath too.
Okay. So in this particular case, I'm also going to apply a nasal cannula to Jim to help with his respiratory distress. He's not in great respiratory distress. Should that change, then I could either up the flow of a nasal cannula, or I could also consider the application of a non-rebreather mask. So right now I'm just going to apply a nasal cannula at 2 liters and see if that helps with his oxygen. His O2 sats for the most part are pretty good. He's hovering right about 95, 96%, so I'm not too concerned about it, but I do want to keep an eye on it. So I've got everything done with breathing. I've done everything I need to do with that. So I'm going to move on to circulation. So I'm going to assess for both a radial pulse and also a central pulse. In this case, he's got good pulses, a very strong radial pulse. I do note that it is rapid. And it's strong as well, but this is also to be expected with somebody experiencing chest pain as the body starts to compensate, and also the patients typically become quite anxious as they're not sure what's going on. Even if it isn't a heart attack or cardiac in nature, it feels that way, and that passes on to the the patient's mental status as well. So while I was assessing his pulse, I also was able to assess his skin condition. So he was sweaty, which is to be expected with chest pain. His skin does look a little bit pale, which ties into the signs and symptoms as well, as we kind of put the whole picture together. Having chest pain, his skin is sweaty, he's having a little bit of respiratory problems, his skin's pale. So I'm assessing him and I'm thinking, you know what, this is probably a situation in which he may very likely be having a heart attack, and I want to get him moving. So I've assessed his circulation. Again, at the general impression, I didn't see any obvious killer bleeds, so I didn't verbalize that right off the bat. You also wouldn't expect to see these typically in a chest pain patient. Not to say it couldn't happen, but I've checked his pulse, I've checked his skin parameters. I don't have no killer bleeds to control. So I've made my decision as a load and go. All right, so based on his condition, I'm going to treat this as a load and go patient. We're going to simulate moving him to the cot, then moving him onto the ambulance, and we're going to do the rest of our assessment very quickly, what we need to get on scene before we start transporting, and then the rest of our assessment and treatment is going to be done in the back of the ambulance. So what I'm going to be doing now is I'm going to have my basic partner get vitals. I want to get a blood pressure, I want to get a respiratory rate, I want to get a pulse, an actual pulse, and I want to get his blood sugar. So while he's doing that, I'm going to actually work on getting his sample and his OPQ-RST so that I know how to better treat him, or if I can even treat him at all, depending on if he has any allergies or anything like that. Besides the chest pain and a little bit of respiratory problems, is anything else going on today?
I feel a little sick to my stomach too.
Okay. Nausea, vomiting, anything like that can be common, especially with people having an active MI. Typically, too, this is kind of a quote-unquote telltale sign if they're having excruciating chest pain with respiratory compromise as well as nausea or vomiting. Pretty good chance that this is pretty legit and this is really what's going on. Are you allergic to anything?
No.
No? No allergies?
No.
Okay. Any food allergies or anything like that?
No.
No? All right. Do you take any medication?
I mean, yeah, I do. I take one.
Okay. Well, what medication do you take?
It's Viagra.
Okay. So it's important to note, especially with Viagra, Levitra, Cialis, any of those classifications of drugs, depending on when they've taken them, we have to withhold nitro from them. Also, as you know from when we talked about in our pharmacology presentation, when to withhold these medications. When's the last time you took one of those?
It's been a week.
A week? Okay. So we're outside of that 48 to 72 hour window, but it is still something that I may be concerned about. One, I want to make sure that, the patient did self-admit that he's taking these, which is good. I'd rather find out now that he's taking these rather than after I give him a nitrate and his blood pressure tanks, and then he finally tells me that he took one of these. Hopefully he was honest enough to tell me that he does take them. Hopefully he's still telling the truth as far as how long it's been, but I do want to still be a little bit cautious with this. So is that the only medication that you take?
Yeah.
Okay. Do you have any past medical history that I need to know about that would be pertinent to today?
No, I'm high blood pressure, but I don't really take medicine for it.
Okay. How do you typically control that?
Just diet.
Okay. So no history of respiratory problems, diabetes,
No.
heart conditions, anything like that?
Okay.
When's the last time you had anything to eat or drink?
I had lunch earlier today.
Okay. What'd you have for lunch?
A hamburger.
Okay. And what were you doing when this happened?
I just finished cleaning up the kitchen from lunch and my chest started hurting really bad.
Okay. So I've got a sample history. Now I want to move into OPQ-RST. I know the onset as far as what he was doing, but we'll move on to provokes. Sitting down or does anything you do make it better or make it worse?
No, I waited a while to call you guys. I wanted to see if it would go away, but it's not. It's not going away. That's why I called.
Okay. Does it radiate anywhere? Does your chest pain travel anywhere?
No, I don't think so. I mean, my jaw feels a little funny, but I wouldn't say it hurts.
Okay. What do you mean by funny?
I don't know. It's like dull.
Okay. All right. You always want to be careful too with the radiate question, and really any of the stuff in OPQ-RST. You really want to try not to lead the patient on to answering. A lot of times they'll think that these are things that you want to hear. So you notice that I avoided asking if it radiates. I didn't further go on to say, does it go into your arm, does it go into your jaw, does it go into your back, or anything like that, because they may think that these are things that you want to hear, and if they don't present with those symptoms, that whatever's going on may not be legitimate, and that's not the case. But remember not to lead them on. How would you rate the quality of your pain? Like, what does it feel like to you?
It's really heavy, like something's crushing me.
Okay, kind of like somebody's on your chest, or
Yeah.
you can't get good chest rise and
Yeah.
fall, something like that. Okay. If 0 was no pain and 10 was the worst pain you've ever had, what would you rate that pain to be?
It's probably a 7 or an 8.
Okay. You said you waited a while to call us, but how long has this been going on?
Maybe an hour.
Okay. All right. And it's been the same the entire time?
I think so, yeah.
Okay. All right. So I've got my sample. I've got my OPQ-RST. I know that what he's allergic to, what I could potentially treat. And I also know a pain scale of, if I decide to give this guy nitrates, where his pain started and where it may end up if I give him a dose or subsequent doses of nitro. So my basic partner came back and he gave me vital signs. So let's simulate here that I've got a blood pressure of 110 over 68. I've got a pulse of 92. I've got a respiratory rate of 18 and a little labored. And my SpO2 is holding steady about 97%. And he gave me a blood sugar of 116. So all those are within normal parameters. Nothing really concerns me about those, but I do need to know, and I need to make sure that I've got a good set of vitals and I've got a good history and specifically allergies on this patient before I consider treating them. Have you ever taken aspirin, sir?
No.
Okay. I'm going to go ahead and give him 4 81 milligram tablets of chewable baby aspirin. I'm going to take those out. I'm going to put them in the lid, and I'm going to have him take them out. If he's not able to actually reach into the lid and take them out, then what I'm going to do is have him open his mouth, and I'm going to put them in, have him chew them up, instruct him to chew them up, and swallow them. And so you remember from pharmacology what that does. Aspirin is a platelet inhibitor, so those platelets become kind of slippery and they don't stick to each other. So if there's already buildup of material inside his arteries and veins and things like that, we're hoping to not have those platelets continue to stick and create a blockage, because that's likely what's going on here. We want to make sure that those platelets are able to quickly move through. So then I'm going to consider nitro. His blood pressure is good. I am going to watch it, though, knowing that he has a past history of taking Viagra. I'm going to watch it, see what's going on, but I'm in that safe parameter to be able to administer nitro. So I'm going to administer 1 spray of nitro, which is 0.4 milligrams, 1 metered dose. What I'm going to do, whether you have nitro tabs or whether you have nitro spray, they both go under the tongue. Remember, the nitro tabs just dissolve, and the nitro spray, of course, is a liquid, so it's going to just absorb into the sublingual area of the oral cavity. So I'm going to simulate nitro. I've got a spray of nitro here. Sir, what I want you to do is open your mouth, and I want you to touch the tongue to the roof of your mouth. Okay, can you open a little wider for me? There you go, good. Okay, I'm going to spray that in. Now, I also do want to warn him of the potential side effects. Nitro is a vasodilator, so it's very likely that he will experience a headache. And typically, it's a pretty strong and pretty severe headache. So you want to make sure that they know this. Some people do think that it's a allergic reaction or anything like that to the nitro, but it's actually more or less the desired effect. We would expect to see that happen. So I know that he said his pain was at a 7 or an 8. I gave him the spray of nitro, so I'm going to wait 5 minutes, and I'm going to reassess him. We're going to simulate that it's been 5 minutes. I'm going to have my partner take another set of vital signs, and I'm going to assess his pain while he's taking the vital signs. So your pain was at a 7 or 8 before I gave you that first spray of nitro. Mm-hmm. Did that help at all?
Yeah, it's probably down to a 5.
Down to a 5? Okay. So we like to see the pain go down, and of course our ultimate goal is to get that pain down to a 0. But remember that we've only got 3 sprays to work with unless we do get medical control order for additional sprays. Unlikely that we're going to do so for a couple of reasons. One, we got to pay attention to the blood pressure, and two, most times we really don't have too long of a transport time. So to get those 3 sprays done, we're talking 15 minutes. So unless you've got a longer than 15-minute transport time, if you were in the 30-35 minute range, maybe. But otherwise, you're going to max out on your nitro about the time or even before you get to the hospital. So I got my blood pressure back. Let's say that his blood pressure is down to 102/70. Remember, the cutoff for nitro is a systolic of 90. So the first nitro dropped his systolic blood pressure about 8 points. It's not a hard and fast fact, but it's safe to say that I would be safe in considering another spray of nitro based on the fact that the first one only dropped at about 8 points. So he's still at about a 5 or 6, so I'm going to go and give him another spray of nitro. Same directions as before. Okay, gave him the nitro. We're going to wait 5 minutes, and then we're going to reassess. So my partner is going to reassess his blood pressure, pulse, respiratory rate. We don't really need to mess around with his sugar again. Okay, your pain was at a 7 or 8 before the first nitro. We gave you a nitro. You said it was down to about a 5 or 6. Is the pain continuing to go down after the second spray?
No.
It's staying at about a 5 or 6?
Mm-hmm.
Okay. It's not rising or anything, right? Just kind of staying where it's at? Okay. How are you feeling otherwise? Do you have is your pain still radiating anywhere or anything like that?
I don't notice it in the jaw as much. I'm still just a little short of breath.
Okay. How are you feeling with the nitro? I know with the chest pain, how's your head?
I've got the headache you were talking about.
All right. Are you still feeling okay sitting up? Are you not getting lightheaded on me or dizzy or anything?
No, I don't think so.
Okay. So then the second nitro really didn't seem to work. I still have that third dose in my pocket, so to speak, that I can give if I want to, but I'm going to wait to see what the vitals come back as. In this case, we'll say that the vitals came back at about 94/58, and everything else is within normal parameters before we had before. While I'm still entitled, I can give that third spray of nitro. I'm probably going to hold off because we're only about 4 points away from the 90, and I don't want to bottom his blood pressure out because I really don't have much to get his blood pressure back up with. I also would make the consideration, and I should have said this earlier in the video, for a chest pain call, I am going to want additional resources. I'm going to want to get advanced life support headed my way so that they can intercept. So I'm going to hold off on another nitro right now. We're going to see how everything goes. I don't want to get your blood pressure too low, but we're on our way to the hospital. I'm going to work on getting a 12 lead on this patient. Actually, I'm going to have my patient work on getting a 12 lead, get him hooked up so I can see what's going on. Once that prints, I'm going to interpret what the back end of the 12 lead says to see if it tells me on the script whether he's got an MI or whatever is going on, and then I'm going to work on transferring that to the hospital through my monitor. So the only thing really left for me to do, I've been continually reassessing this patient. The only thing I haven't done yet is a physical exam. I don't feel the need to do a head-to-toe. I've done my ABC, so I kind of know where his chest cavity stands as far as his breath sounds and things like that. But I want to do a focused physical exam. So I would want to expose his chest. I would untuck his shirt, lift his chest up, probably about up to his chin or so. Make sure that I can actually see good chest rise and fall. I'm going to listen to lung sounds again to make sure that those haven't changed. And I'm just going to overall check my patient to make sure I don't see anything else going on. Since he is having chest pain and breathing difficulty, even though he says he doesn't have any other respiratory problems or cardiac problems in the past, I am just going to take a quick look at his legs to make sure that I don't see any sort of pedal edema in his legs or feet or anything that would indicate that we're looking at either a sudden onset of heart failure or if he's got a history of heart failure and failed to mention that, whether he just forgot about it or didn't want to talk about it. So I've got my assessment. I'm going to continue to reevaluate him. He's a priority patient, so I'm going to reevaluate his vitals every 5 minutes, even if I'm not going to give more nitro. And I'm going to call my report into the hospital and make sure they know what's coming. And then once we get to the hospital, we'll pass off patient care.